In oh 01. Here we go. I want to thank you all so much for joining us today. My name is Dr. S.K. Moreland. I'm the founder of HIM Concierge Services, where I help new and existing professionals navigate their career. And I'm so excited today because I have my very dear friend, Keisha Wilson, who is going to be presenting to us about telehealth's impact on social determinants of health. Social determinants of health is something I'm very passionate about, most importantly about being able to address those socioeconomic factors that really impact our health. Like where do we work? Where do we live? Things of that nature. Somebody's drawing on the canvas back there. But of course, I'm so excited that Keisha's here. She is a dear friend. We talk all the time, and I've learned so much about her from her experiences and being able to just grow professionally and individually. She is a blessing. So before she gets started, I'll do a brief intro of her background. She is the founder of KW Advanced Consulting, and she's a seasoned professional with over 20 years of experience in the healthcare field. Her career in large teaching hospitals and acute ambulatory care systems involves roles such as outpatient coding specialist, clinical documentation improvement specialist, compliance operations, coding and billing manager, interim compliance director, and consultant to various coding companies. Her extensive experience is a testament to her leadership and deep understanding of the industry. She's not just a subject matter expert in compliance and revenue cycle management, but she's also a dedicated educator and trainer. She excels in risk-based audits, retrospective, prospective evaluation and management audits, and auditing and coding of multi-specialty documentation and coding telehealth, telemedicine services, risk adjustment, HCC provider, and coder education, training, and webinars. She has developed and implemented numerous compliance documentation and coding training programs for organizations of all sizes. She's an approved instructor for KW Advanced Consulting and an adjunct professor for the American Academy for Professional Coders, teaching a wide range of compliance and coding courses. Her dedication to sharing her expertise extends beyond her professional roles. She serves on the board of directors for an outpatient mental health clinic and actively participates in various telehealth and compliance committees. And as a published author, she regularly contributes coding articles for KW Advanced Consulting, keeping the industry updated with the latest developments. Her collaboration with AAPC editors on various primary care coding alerts and AAP magazine is a testament to her commitment to advancing the field. We're so excited to learn more about the topic today, and with that, I will turn it over to Keisha.
Yes, I was muted. Thank you so much for the amazing introduction. Um, and I'm so happy to be here and present on such an amazing topic. Telehealth and social determinants of health by itself, both of them are super important. Together, you can imagine how much information we could be here talking probably all year about both of them, but we won't. You have me for the next hour. So we're going to talk about telehealth and the impact of social determinants of health. If you don't know what telehealth is, I'm going to explain it to you as well as social determinants of health and how we can utilize it to bridge that gap. Just a little disclaimer, so this presentation is intended solely to provide information to the public. Of course, you don't want to rely on it for financial, medical advice, y'all, or legal advice, right? You always want to do your due diligence as coders, auditors, HIM professionals, administrators, CEOs. We always want to do our due diligence and research. So I hope this is the foundation for you today for researching the topic and continue to research and implement any key areas into your organization where it may be lacking. I won't, you already have the whole slew of me. Thank you so much for such an amazing introduction. Sometimes you forget all that you have done. And you just, once you get to do what you love, it's just so important and I love it. So what are we going to talk about today? We're going to talk about the leading causes of death in the United States. Social determinants of health, what is it? And how does it look like across the United States? Do you know that it depends on where you live geographically, that some areas may be impacted more with SDOH than others? If you don't, stay tuned. We're going to talk about telehealth, what it is. You may have heard the term used interchangeably, telehealth, telemedicine. So I'm going to help you with that. How do we align the two and how does it work together? The impact of chronic disease management, CPT codes that you would use, some screening tools that have been created, and then summary, right? It's a lot. So hold on to your seats. I hope you have a notepad to take documentation down. The teacher and me are going to stress certain things. So the leading causes of death in the United States, there is a lot, right? So this is not all, but the CDC, CMS kind of lists these at the top. So we have heart disease. It varies, right? From ischemic heart disease, cardiac death, heart attacks. We have strokes as well. We have cancer, the chronic lower respiratory diseases, accidents, Alzheimer's disease, and it comes along with dementia. With dementia, that there's manifestations such as Parkinson's and other stuff that can come along with dementia. Kidney disease, whether it's end-stage renal disease or chronic kidney disease, and maternal death. Maternal death is significant, especially among the African American community in the United States. I think time and time again on the news, we're always hearing about someone that may have passed away, during childbirth, right? And leaving the fathers to raise the kids. So, social determinants of health, what is it? Let me know in the chat. Have you heard about social determinants of health before this webinar, or is this the first time that you're hearing about it? I always like to know the audience and who I'm speaking to and how much information you know about social determinants of health or telehealth. Let's take a look. First time. Okay, awesome. First time, but it won't be your last time. I'm sure you're going to leave interested. Let me know. I would be curious to know at the end. So, what is social determinants of health? It is conditions in the environment where people live, where they're born, where they learn, where they worship, where they work, where they play, right? Just think about it. Think about you, I've heard it a little bit. Okay, awesome. So think about it. Where you live now, it's the environment, the overall environment where we work, where we live, where we worship, go to church, that affects our health, the functioning, the quality of life, our outcomes, and risk. So conditions such as, and we're going to go through it, social economics, we have physical. So in these various environments and settings, such as school, churches, workplace, and neighborhood, they come together, they affect the overall quality of health in the patients and how they are able to be treated. So such things as availability to resources, right? Housing, local food market. There's homelessness, food insecurities, access to educational, economic, and job opportunities. We have access to care, quality of education and job training, because that does impact transportation, public safety, social support, social norms, discrimination, racism, exposure to crime and violence, and then different economic conditions, right? Poverty, stressful working environments, residential segregation, language and literacy, and culture. So when you think about it, and I oftentimes use this example, right? For example, I just listed out a lot of the things, and you can see on the screen, we have economic stability, and under economic stability, we have employment, income, expense, debt, medical bills, and support. So I want you to think about it, depending where you live. Even though I'm here in New York City, and it's a huge city, there is a significant um, poverty level. There's a lot of homelessness. We have a lot of people that lost their jobs. We know we have new administration right now. We know there was a lot of people from the federal government who have been laid off, and then others, right? So if you think about it, and I used this example during COVID, I said, for example, you have a patient that lost their job. When you think about it, when they lose their job, what else do they lose? Oftentimes, their insurance. And if they're on medication, they're unable to take their medication and afford a medication. Therefore, you have, if they have chronic conditions, then they have an increase in exacerbation. So they have an increase in their worsening chronic conditions, right? Where they may end up in emergency rooms, urgent care, admitted into hospital. But besides that, so we have loss of insurance. The providers are unable to treat them because they lost their insurance. Then you have homelessness. A lot of them have lost their homes and have gone into homeless shelters. You also have food insecurities, right? You have lost your being able to afford food. So there's a ripple effect when a lot of these things happen and we don't really think about it. You have the neighborhood, physical environment, housing, transportation, safety, parks, playgrounds, and walkability. So, going back to economic stability for a second, employment and everything, it's huge. There was an article in the New York Times a few weeks ago that stated a lot of the working class are in homeless shelters because they don't make enough to afford the rent in New York City, but they make too much to afford affordable housing. So they're stuck in between, so they're in homeless shelters and they can't afford to move out to another state, right? So we have that, and you're seeing that in a lot of cities. I visited HealthCon, there was in Florida, and then I visited a few other cities like San Diego's and stuff for travel, for work, and you see the homelessness, right? You see the job insecurities, and you see the ripple effect, and it really affects the health and how providers are able to treat them. So when they come in, there's screening processes that have to take place, and we'll talk about that. For the different patients that have chronic conditions, they lost their insurance, or even if they have insurance, they have significant bills depending on what's being treated. And what does the support look like? Do they have family support? When my mom went through cancer treatment, and I took her to her appointments. It's a huge Manhattan hospital with a floor like a block long. And there was a lot of patients by themselves, right? So not everyone has that support. So when the doctor is speaking to them, telling them to follow medication guidance, if they don't speak English or even if they don't have that support, they may not be hearing what the provider is telling them because oftentimes they're thinking about the diagnosis, right? So you kind of tune certain things out. So think about that. The housing, I just mentioned, we have a lot of homelessness. Um, I think about the cities where you're in, but definitely in New York, I'm gonna use an example. We see buildings going up time and time again, but they are not filling them, right? There's no one really to afford those housing. Transportation is an issue, even though we live in a busy city. Not everyone has access to a car. Some people are scared of public transportation due to the violence, so they may not want to get on the buses or the trains. You have certain things like accessorize, but then sometimes they drop the patients off too early, where the doctor's office is not open yet and they're outside for hours. And if depending on the condition, they may not be able to stand that long, or they're picking them up late, or they're just taking them to drop off other people, right? So I've had family members complain that they've been in these ambulettes or accessorized for like 3 hours and late to their appointment. So there's a lot of concerns. And think about the people that live in the rural health communities, the rural health areas. At HealthCon, there was someone that told me she has to drive 45 miles to get to a doctor's office. That's a lot, right? So this is where things like telehealth, what we're going to talk about, helps. Walkability. We don't all live in an area where we're able to walk, right? Half of the places may not have sidewalks. They're unsafe. When I talk about homelessness, I worked when I was in college, I had to do an internship. My internship was at a teen shelter called Covenant House here in New York City. And funny enough, a lot of people let me know. I don't know how many of you have ever visited New York City. Everyone loves to go on 42nd Street. It's like a lot of lights, glamour. It's so much excitement. Let me know, has anyone ever visited and went with their family on 42nd Street? It's really intense, right? It's a lot of fun. But what a lot of people don't know that there's actually a homeless shelter 1 block away on 41st Street. And that's where Covenant House is. And I was like, a lot of people don't even know that 1 block away, we're dealing with homelessness with teenagers. And there's also an adult shelter. Oh, you've never been. One day, Kelly, and you'll let me know what you think when you visit. Um, and 1 block away on 41st Street, we have a homeless shelter, right? Teen shelter and adult shelter. The teen shelter house teens and pregnant teens with mom and baby. So we saw a lot. I saw a lot when I did my internship there. Education, it plays a difference, right? Language, right? We may not always understand what the provider is telling us because we have that language barrier. Literacy, some patients may not have went to school at all because depending on the country or where they worked, where they grew up, they had to work from a young age and they never went to school. So the provider talking to them about certain chronic conditions, they're not understanding. Telling them how to take medication, they may not understand that. Oh, they need to change their diet. But culture plays a factor with how we eat. And we're going to talk about that in a second, too. Also, early childhood education. They may not have somewhere to put their children, right? So going to appointments may be affected. These are all things when we talk about social determinants of health. Food, hunger, access to healthy options. I teach a class also at a local college here in New York City, and it's a patient care navigator course, right? So we teach students if they want to go on to be patient care navigators, there are that bridge between the physicians and healthcare, right? And we talked about hunger and we talked about food in different places. Here we have what you call mom and pop shops, bodegas, local corner stores, where from the time we've grown up, we've gone to get food, a lot of the food. And so I gave them an assignment to go into one of those places or even open their cupboards and look at their favorite foods and tell me what shocked them by reading the label on some of these foods. And one thing that came up time and time and again is what? Sodium. A lot of foods in these places are high in sodium and high in sugar. But because this is what a lot of locals could afford, this is where they go because the food is cheaper. But then when we look in certain areas, we can understand why some places like the Bronx and Brooklyn will have a high hypertension because they're ingesting a lot of sodium, right? So there we talk about social determinants of health and the food that we eat, access to food, community engagement. I also gave them an assignment of to look around the area and what resources do we have for our patient population. A lot of them were surprised that we don't have a lot of resources and these patients have to travel to other boroughs. Then discrimination, waiting a long time for appointments, the quality of care because the patient has just straight Medicaid or Medicaid. They're going to the clinic. When they go to the clinic, they have to wait 4 hours for an appointment versus being seen right away. They feel like they're not getting the best care at the clinics, right? So it's a lot when it comes to that. And, at HealthCon, I talked about it a little bit. You know, for myself and my mom, we had to deal with social determinants of health. We teach things, right? And I always say God is funny. Well, funny how he sets things up, right? It's a topic I love, social determinants of health, telehealth. I always talk about it, but we had to go through our own SDOH. And I was like, I wasn't sure if I was going to share it, but I'm learning to tell it because as Dr. Morland and I was talking about it, it becomes a part of us, right? So last year, August, the end of August, 29th to be exact, we lost our home. The home that we owned for 20 years because my neighbor's house had a gas leak and gas explosion, right? And just like that, in a split second, the home was gone, right? And the city of New York required it to be fully demolished. And so right away, we go from having a home to being homeless, right? Because we had to stay in a hotel, and then the insurance, we had to find some place to rent temporarily until their home is built back. As of June, right now, 26, the home has not been built back. That's another issue by itself. Um, and we're figuring out next steps, right? Because they're only covering a year. So there was homelessness, there was food insecurity, because guess what's in your house? Food, right? So everything you had, food is gone, clothing is gone. And my mom, for example, ran out the house. barefoot, glass all in her feet, right? And she has some chronic conditions, post-cancer and everything that she's dealing with. So right there, my sister and I had to jump in, get on a call, call the doctor's office, set up telehealth visits to address her immediate social determinants of health. And so now, besides just speaking about it, I had to live it so I understand it, right? What people have to go through with certain things and navigating that space, and how telehealth has helped me and helped my family be able to deal with those immediate needs. So think about it. And we have a lot of patients that live in those rural health communities. So we have food insecurities, as I mentioned, coping mechanism, chronic disease. Unfortunately, I would say chronic disease comes along with others, manifestations. Oftentimes, you may see a patient that has hypertension, they may have some type of heart disease, heart failure, they may have chronic kidney disease, you may have a patient that has diabetes that also has chronic kidney disease, neuropathy, retinopathy, polyneuropathy, right? So it's affecting their eyes, their feet, their nerves, because they don't come alone. I always say they come like gray hair. Once one gray hair come, you just get a lot and it's a very annoying. But unfortunately, this is how chronic disease works. So if we don't manage it, some medications could cause something else. And it's like a ripple effect with that too. There's decreased employment, which we're going through now, and decreased household income. And so this is like the circle of life, which you hate to call it that, but that's what it is. Then we also have the SDOH, right? We talked about transportation, childhood care, legal concerns, income and financial, family support. There's not always that. Um, moving, race, ethnicity, disability status. So, I use New York as an example. Even though there's subways, not all subways have elevators. So if someone has a disability and in a wheelchair and have a hard time walking, how do they get to their appointment? So all things we need to think about. The neighborhoods, right? Not all of them are safe. So they're scared to come out at night or even in the day for an appointment. States where you live, right? So life expectancy rates in the United States vary significantly from state to state, reflecting a range of factors including healthcare access, lifestyle choices, and socioeconomic conditions. So depending on where you live in the states, you may see certain things, right? So those that live in a rural health community and have to drive miles and miles for appointment to the grocery store, you tend to see more obesity. You tend to see more diabetes, high in diabetes, right? Because obesity is another one of the manifestations of diabetes. So it's usually, and when you think about it, when you go to the doctor's office, right? They tell you you're borderline with diabetes, um, what do they try to control? Your diet and exercise. They try to get you to walk, to reduce certain foods. So think about that a bit. According to the recent data, the average life expectancy in the United States is about 75, 77. I would say 77.5 years, but the average mass, it changes significantly from state to state because of that, right? And access to care. Remember, I said here in New York, we're a little lucky, Texas, you guys, different states that are, Washington, they may have more access than someone in Oklahoma, in Ohio, right? They have to drive miles and miles away. So, in contrast, for example, to Mississippi, they had the lowest life expectancy of 71 years old. So the state faces significant public health challenges, included high obesity of about 3.1%, which is one of the highest in the nation. Other states have high expectancy rates, including California, Minnesota, which is 79 years old, um, and Washington, which is about 79.2 years, right? So you can see it depends state to state. Other states, such as West Virginia now, they live about 74, Alabama 74, Kentucky about 75, and they're among those with the lowest life expectancy, often due to high rates because of chronic conditions. So the Organization of Economic and Cooperation and Development, also known as OECD, notes that the life expectancy at birth is influenced by, guess what? a variety of factors, including genetics, environment, and access to quality of care and healthcare. I always say, when it comes to food, some of it is learned behavior because I was born in Grenada. We're from the Caribbean. We tend to, I went to a doctor's office with some family members, and the doctor was saying, diabetes and certain chronic conditions, yes, they say it's genetics, but we also, guess what? When we learn to cook, who teaches us to cook? Oftentimes our parents, our grandparents, right? So they're cooking a certain way, they're cooking with a certain seasonings. In that same patient care navigation class, I had them look at seasonings, certain things like sazon, adobo, and look at the sodium, right? So when we're cooking, we're putting all those things. Caribbean people like to eat a lot of carbs, so we'll have like the macaroni and cheese or the macaroni pie, the potato salad, the rice. A lot of starchy foods, and guess what? All those starches turns to what? Sugar, right? So you wonder why diabetes is high in certain cultures or certain parts of the regions. And it's because we learn how to cook. It's passed down from generation to generation. So when they say genetics, I'm like, we can change that if we just learn different patterns, right? And so this was all the stuff when it comes to that patient care navigation course that I was teaching. Significant health disparities persistent across the United States, influenced by race, ethnicity, geographic area, socioeconomic status. Believe it or not, some chronic conditions affects male versus females. Also ages, right? The older we get, sometimes we're more susceptible to chronic conditions. And then the status. So minority population in rural communities often face elevated rates of chronic disease, poor health outcomes, and limited access. So for diabetes, we have the American Indian is about 16%. Black non-Hispanic is 12.5%, Hispanic is 10.3, and white non-Hispanic is 8.5. So in rural areas, the prevalence of diabetes is notably higher, 14.3. Because guess what? Remember I talked about transportation issues, so they may not be moving. If you notice that during the public health emergency, diabetes and certain conditions spiked because guess what? Everyone was home. Everyone was kind of sedentary, right? Heart disease and cancer, rural communities experience higher rates because getting to these doctor's appointments, there's not access to care. They have to wait a long time. They have to drive a long time. I think it's crazy when you have to call a doctor's office and they tell you the next available appointment is December or January of 2026. And I've heard that. I continue to hear that. And this is where telehealth comes in. Homelessness. In 2023, the United States Department of Housing and Urban Development releases its annual homeless report, which states 653,000 people experiencing homelessness on a single night in January 2023. That's 2023. So you can imagine now with the job market and a lot of people being laid off. So this is 12% increase from 2022. Then we talked about the lack of transportation. Studies consistently show the lack of transportation is major barrier in healthcare. So I talk about it when it comes to telehealth in a second. It helps, right? If you don't have the means to get to a doctor's office, you can log on from the comfort of your home. But hopefully, right, you have internet service. That was another barrier that we are working with. Organizations like the American Health Association and the National Academy of Medicine highlight the transportation as a key social determinant of health. Hunger. Annual report of household food securities provides data. 2022, 44.2 million people lived in food insecure households. So there was another assignment I gave students, and it was actually real data. The patient was on Social Security. She had kids. Her income on Social Security did not allow her to afford her rent as well as pay utilities and buy food. So she had to choose. And guess what the patient chose? She chose to pay the rent, right? Because if she doesn't pay the rent, they won't have anywhere to live. So they paid the rent, but the utilities were shut off. The food, they didn't have food to eat, right? So you got to think about these things. Um, In 2022, 12.8% of United households were food insecure. So in comes telemedicine. Telemedicine, what is it? So I'll give you the two definitions. At this point, they are used interchangeably depending on who you talk to. So telemedicine is the practice of medicine using technology to deliver care at a distance. It occurs using telecommunication between a patient who's at an originating site and a physician or other practitioner licensed to practice medicine at a distant site or hub. Telehealth is the use of telecommunication information technology to provide access to health assessment, diagnosis, intervention, consultation, supervision, and information across a distance. So it seeks to improve patient health by permitting two-way, real-time, interactive communication between the physician and the patient at distant sites. So you see, initially telemedicine was used, and it's been around for decades. NASA was one of the first people to use telemedicine, telehealth. Initially, it was physician using it to communicate about patients, and then they started to utilize it in patients. It started in like the early 1960s. A lot of people don't realize that because we only kind of heard about it after the public health emergency, but it's been around for decades. I'm a part of the International Society of Telehealth and eHealth, and they have been around for a long time in fostering and lobbying for telemedicine to help with disparities, right? And all these social determinants of health that we talked about. So telehealth is like the umbrella, right? We can use it for different things, such as supervision, so resident and physician supervision, talking to the patients, assessments, such as social determinants of health. Initially, Medicare did not pay for a lot of services, so there was not a lot of buy-in initially, but the public health emergency changed that because right away the world was shut down and we had to figure out continuity of care and treating our patients with chronic conditions. So this is where telehealth helped. Let me know in the chat, have any of you used it personally or anywhere do you work now, do they utilize telehealth? The ATA, the American Telehealth Association, uses this interchangeably. When we talk about telehealth, we also talk about synchronous and asynchronous. Oh, I think someone's accidentally writing up on the screens, but no problem, as long as you guys can see what I'm writing. So synchronous real-time audio-video communication that connects physicians and patients in different locations. So I always get that question of the patient being in the same location, and I always say, let's go back to the definition, right? The definition says the patient is at an originating site and the physician is at a distant site. Because before, when we had telehealth pre-COVID, the patient had to drive to a location and then they would check them in, they would set them up in front of a computer, and the physician would be at a distant site being able to treat them on a different screen. So this is where we have something which we call a facility fee, which is a CPT code HCPCS Q3014. For when those patients go to a facility, those facilities can charge that fee because, you know, they're paying, right, to process the patient. Versus when the patient is in the comfort of their home, they cannot bill that extra fee because guess what? You're not paying the patient's rent, light, gas, or anything else, right? And then we have asynchronous, which is store forward technologies that collect images and data to be transmitted or interpreted later. We have what we call remote patient monitoring devices or tool, such as blood pressure machines, Bluetooth enabled devices, wearable machines. So any of you ever saw those patients or people walking around with those little white circles on their arm and wonder what it is? Oh, you used it many times. Yeah, I love it. Okay, you both did awesome. Yes, me too, and I love it too. Those little white devices are remote patient monitoring, which is monitoring those patients' A1C or their blood level sugar or their blood sugar levels when it comes to diabetes. And the providers are getting real-time feedback. Then we also have the online digital visits, audio only services, which is patient portals, for example, smartphones and landlines. So we have two, synchronous and asynchronous. The remote patient monitoring, as I mentioned, so it allows physicians to be able to get real-time feedback on their patient status and their conditions right away. Um, High blood pressure, diabetes, weight loss are some of them. This helps. It has increased significantly during the public health emergency and after, because now providers didn't have to wait till their patients had an exacerbation and was admitted into the hospital. They were able to now get real-time data on the A1C. And they get that alert, they will call the patient, let them know, you know what, you need to go to the closest emergency room, or you need to come into the office, or I'm changing your medication, calling this into the pharmacy. I want you to continue to check. We're going to continue to monitor you. And so they're able to control their patient chronic conditions at a different level because of the remote patient monitoring. Now, when billing for this, there's a lot of levels of detail. The OIG, the Office of Inspector General, actually did an audit recently and stated that a lot of the documentation that they looked at, let's say over 100, let's say they looked at 110, 105 did not support, meaning that the providers did not satisfy the documentation to bill for remote patient monitoring. So anytime you're billing for CPT codes, you always got to make sure it's following the coding guidance and what they require is there. So originating site, distant site, I talked to you about this. The patients will be at an originating site. And right now, due to the Consolidation Appropriation Act of 2023 and the American Relief Act of 2025, Medicare patients and others can continue to get services and get telehealth from the comfort of their home. So they can stay home and get telehealth. They don't have to go into an office. The distant site, the physicians are at distant sites. And right now, they have extended that physicians do not have to report their home address right now because of safety reasons. This has been extended until December. I gotta close my eyes to think of these dates. They're all in my head though. December 31st of 2025. And then we're waiting to see if Congress will extend that or make it permanent. The ATA, the American Telehealth Association, had a letter on President Trump's desk the day he was inaugurated into office to make a lot of the telehealth services permanent. So they're lobbying and they're fighting to make a lot of these things permanent because of the data, right? It has helped. Healthy People 2030 objectives, right? Help measure our nation's progress in critical areas of public health and serve as a reliable data source to support organizations and individuals working to improve health and well-being for all. So when if you decide to Google 2020, Healthy People 2030, or you'll find all this information when it comes to suicide and all the SDOHs that we're talking about, and they're trying to address and focus in upstream measures such as risk factors, behaviors rather than just the disease outcomes, address the issues on a national level, right? And making it high priority and a public health issue. So you'll continue to hear about the interventions, and this is where social determinants of health comes in and the screening tools. Remote consultation, so telemedicine provides access to primary and specialty care for patients in rural and undeserved areas where healthcare facilities are limited. Chronic disease management, we have remote monitoring, which enables continuous care, as I mentioned, and reducing the need for frequent in-person visits and being admitted to the hospital. Mental health support. We have psychiatry. Telepsychiatry expands access to mental health services, particularly in areas with shortage of mental health providers. And I'm going to talk to you about what HRSA and the Social Work Compact is doing in a little bit to expand this. So, how telehealth addresses SDOH? It gives access to for specialty physicians. Oftentimes, you'll have to wait months and months, right? But instead of waiting months and months, patients now just have to wait maybe a few weeks, even a few days to be able to see a specialist, such as endocrinologists, cardiologists, nephrologists, OBGYNs, you listed. And it helps with continuity of care. Um, because they can continue to treat the patient's condition in such a timely manner. So it enhances follow-up care by allowing patients to maintain regular appointments without the geographic constraints. Then we have timely interventions, which is basically early detection and intervention by facilitating quicker consultations, reducing disease progression and complications, right? Remember the remote patient monitoring, like I told you. Patient-centered care. So it offers personalized care plans and remote patient monitoring and treatment plans as it relates to those particular patients. Language and accessibility support, so it provides access to multilingual providers or interpretation services, improving care quality for non-English speaking patients. So they have access to interpreters. Collaboration, collaborative care models. So there's various ones. Facilities, they come together with specialists, behavioral health, diet, nutritional counseling. They all come together collaboratively to work on these patients and their needs and their treatment plans. After hour care, when clients call me, so I do various assessments. One, a patient, I mean, not a patient, a practice could be running for years and years, decades, right? And they just need an assessment. There's some revenue cycle management leakage. How can we do better? How can we offer more services or a new practice that's opening and they want to offer services? I would say you want to speak to a consultant, right? Or someone, compliance in your office to look at the codes and make sure you can support it. After hour cares is one, because most doctors' offices are open till 5, but utilizing telehealth after hours, so let's say from 5 to 8 or 9, you can now see these patients later or even earlier in the morning. I myself had a physical the other day, and they said, "Oh, for your follow visit, doctor's going to do telehealth. You want 7 a.m." Yes, telehealth. Oh, perfect. I don't have to drive another hour to see her. Yes, I'll take it. Right? So things like that. They can start earlier and actually go later in the evenings. Accessibility, right? Maybe they're unable to because of transportation. So they are able to log on like we did for our appointments, and it reduces wait times. They don't have to wait months and months to see a specialist or a doctor. So overall usage, 37% adults utilize telemedicine. Gender disparity, about 42% women use telemedicine compared to 31% of men. Age variations, so usage increased from 29.4% from 18 to 29-year-olds to 43.3% of 65-year-olds and over. Racial ethnic differences, non-Hispanic, Indian, and Alaska Native adults had the highest of 40.6%, while Hispanic adults had the lowest of 33.1%. Influence of SDOH, social determinants of health, account for approximately 30 to 55% of health outcomes in the US. That is a lot. And this is just additional graph looking at the numbers that I just gave you because, some people are more visual than numbers. So it's just talking about the men versus women and then the age difference with these numbers, as well as the different variations from Hispanic to African American and Caucasians. So some data. I'm always going to give you data. So Virginia Commonwealth University Health, VCU, has a large service area covering urban, suburban, and rural geographics, continuity of care. So prior to COVID-19 pandemic, nearly all psychiatry visits were delivered in person. During the COVID-19 pandemic, VCU health clinicians have provided about 3 to 5,000 psychiatric visits per week. That's a lot, right? Telehealth utilizes peaked 92% in April 2020 and stabilized to about 80% overall, right? But that's still high. Remember, I said I'm on that board of directors for outpatient mental health clinic. So I know about the need for behavioral health, right? And important about expanding services. And we look at the numbers all the time. Our mission for women of color. So we have InnovaCares, which saw the maternal health and the death rate in the United States. The founder of this program and this app and is amazing. I know he gave his story about, I think his sister passed away from maternal death, and from that birthed InnovaCare, where they now monitor patients' conditions. They have an app, they have a device, and so they can see, if a patient is having some type of exacerbation that's pregnant and deal with it right away versus them being admitted and then passing away while giving birth, right? So, in Overcare, the cumulative effects of these dynamics is to diminish confidence in the healthcare, misdiagnosis, improper treatment, and ultimately worse outcomes for women of color and their babies in the U.S. The ATA, so the American Telehealth Association, created a SDOH toolkit to scale community telehealth delivery, which is a new measure to calculate other tools that will help communities address economic burdens. In addition, remember I said one of the community board members for the ISFTEH, and they have been around for over 26 years now. And they work together for disparities in helping patient disparities using digital health in the United States as well as internationally to help bring down a lot of these chronic conditions and address them. In addition, LabCorp, right? LabCorp is in the mix. LabCorp, these virtual appointments can be further supported. So around 2023, they had some flexibilities with the CARES Act and allowed LabCorp and other agencies to now conduct visits and come to the home to draw the patient's blood, allowing patients to conveniently perform important health screenings such as colorectal cancer screening, diabetes, chronic disease, and by combining video consultations with at-home testing, providers can more effectively monitor patients' health to ensure timely interventions and meet quality measures through individual tests on a broader gap basis, right, for these programs. So integrating telehealth with comprehensive laboratory and pathology services enhances the ability of physicians to make timely and accurate diagnosis. In addition, remember, one thing you guys are going to know about me, I'm going to come with resources to let you know. So when you leave, you're leaving with a wealth of knowledge. In 2023, SAMHSA is a Substance Abuse and Mental Health Service Edition. A lot of you may not know that they continue to expand substance abuse so they can conduct those services virtually and even use audio only visits. They don't have to have an in-person requirement and meet in person before they are admitted into the substance abuse program and behavioral health, and prescriptions can be supplied virtually and audio only as well. And they have noted that substance abuse patients have been showing up for their appointments and actually are more compliant for the virtual visits than in-person visits. But with everything comes, guess what? Fraud, right? And so you have to be careful that the patients are who they say they are, because now we've heard some stories and read some reports of prescriptions being prescribed via telehealth for substance abuse, and the patient had passed away like months or years ago, or right? So someone's using their information. So have to be mindful. But in 2023, to optimize the expansion of telehealth services, communities must have a reliable, affordable internet access. So we have Wyoma Connects is a free internet Wi-Fi network community initiative that brings internet service to low-income, high-density residential communities, right? So this is in Florida. Remember, I said not everyone had internet access, but they were helping because of the patient population to make sure that they had Wi-Fi so they can have these visits. States like Colorado and Minnesota, Tennessee and Virginia, Wisconsin supported the broadband, and then, of course, SAMHSA. The providers who can provide telehealth, the list is long. Medicare has a permanent list of providers. During the public health emergency, they did allow some providers to temporarily provide services. Because of the American Relief Act, there has been some extensions of these services until September 30th of 2025. But on the permanent list, we have the physicians, those are the DOs, the MDs, the nurse practitioners, the PA, the nurse midwives, clinical nurse specialists, clinical certified registered dietitian. Are they on there? Yes, the anesthetist, clinical psychologist, social worker, licensed marriage and family therapist. Certified substance abuse, they were added in January of 2024 and made permanent for marriage counseling as well. So you want to keep that in mind. Telehealth. So when telehealth is used, it's considered rendered in the physical location of where the patient is located. Therefore, those providers must be licensed in the states where those patients are located. During the public health emergency, that was one thing that was waived, and providers were able to see patients in other states. But that has ended. A lot of that has ended even before the public health emergency ended on May 11th of 2023. So the providers must be licensed. This is why we ask some questions before they conduct a telehealth visit. Where is the patient located? Where's the provider located? Some states will allow providers to see their patients temporarily if they have an established patients and the patients are in a certain state on vacation or something, right? But you have to look at those state regulations. There's federal laws and there's state laws. So state laws, if you see a patient in another state and you're not licensed, now that's a crime, right? So this is why we have to ask certain questions. So few states have licensed the out-of-state provider. Idaho, for example, passed a bill which allows a provider that is licensed and in good standing in another state but not licensed in Idaho to provide services when the provider has an established relationship. So they already have seen them. They can't do that for new patients. Consent is important, so providers are to obtain consent prior to rendering services via telemedicine or telehealth. They must get the permission, whether it's verbal consent or written consent. It should be documented best practice in the patient's record. The patient's that's a legal record, and that's how we know they gave consent because there's co-payment deductibles that apply. They're knowing that this is replacing an in-person visit. If anyone else is watching the visit, if the provider has residents or anyone else in the room, they have to get the patient permission. If someone else is attending the visit with the patient, they have to get their permission as well. If the patient refuses and wants to come in to see the providers can't force them, to continue to have telehealth visits. Providers are not allowed to record the visits. There was a lot of states, there was confusion. Some states said you just had to get consent. They didn't say it had to be verbal or written, right? Some states did. Like New York was like, listen, you have to get consent. It needs to be documented. I know there was a lot of back and forth with Texas originally, but Texas, as of May 23 of 2025, Texas now requires documentation, mandatory documentation of consent for telehealth. So it has to be documented in a record, and they also have record retention, right? So that means that they must keep the consent on file for a certain amount of time. So it varies from Medicare, 5, 6 years. HMOs or certain Medicare Advantage plans may require them to have the records on file for 10 years, but they have to look. So now places such as Texas have to update their policies and procedures for a lot of hospitals and doctors' office with this new change. So types of telehealth services, we have virtual visits, primary care, specialties, we have remote patient monitoring, we have mobile apps. They can use they log on to the patient portal, psychiatry and behavioral health, as well as store forward, where they can upload images. For example, we have a code G0136. This is a social determinants of health or risk screening, is a time-based code, and they can now utilize this to screen their patients for social determinants of health. For evaluation and management services, meaning an office visit, an initial hospital visit, nursing facility, if they're using medical decision making, social determinants of health is on the moderate level, meaning they have screened the patient, and they have some social determinants of health and is documented in the record. But in addition, they can have their clinical staff screen and they can build these codes separately to G0136. And it has permanently been added to the list of telehealth services as of 2024. There's also caregiver training. So this was a new code that came about in 2023. And then last year, CMS has made it permanent. And so now it's permanent on the telehealth list. And they caregivers, the patients don't have to be present, but they do have to get permission from the patient beforehand to conduct training. So for those patients that have caregivers, they can have training, to go over different daily activities. They can train them on medications, um, patient safety. And so they can build the first code without the patient's presence. And then there's add-on codes. They are all time-based codes, so time must be documented in the record. There's also group caregiver training. So if they get a group together of caregivers, they can also build and utilize these codes. And all three codes have permanently been added to the list for telehealth. There's also some category three codes in the CPT book, which has been added in, which is health and well-being coaching, face-to-face, individual, initial patient. Um, and they also have follow-up sessions and group sessions. So if there's two or more, depending on that's what they're going to bill for these services. Um, so it helps them set goals to improve their nutrition, as well as provide strategies to deal with chronic illness such as diabetes, obesity. So they also work with them to improve their overall well-being. The coaching includes motivation guidance and support to help individuals stay on track to achieve their goals. In addition, there's education and training for patient self-management by a non-physician, qualified healthcare professional. So those are those nurse practitioners, those PA, the midwives, uh, anyone who's non-physician that's allowed to bill Medicare. These were also added permanently to the list of telehealth services. There are time-based codes, so the total time must be documented in the record. There's also group training, right? So if there's two or four patients, they'll bill the 98961. If it's 5 to 8 patients, they're going to bill the 98962. So we always just have to look at documentation and to see which code is going to be billed. There's also evaluation and management codes. So these are on the list. There's a little confusion that happened. Every year we have some confusion between CMS and AMA. The AMA writes the CPT book. The confusion was that the AMA came out with some new 9.8 series code that I'm going to talk to you about in a second. And CMS said we're not adopting those codes. We already have codes that describe exactly what you created with these new codes. So we're going to utilize the office and outpatient codes. The doctors are supposed to bill the appropriate place of service, meaning O2 if the patient is not in their home, or 10 if they're in their home, and the appropriate modifier. For example, 95 or 93. 93 tells them it's audio only, right? So the evaluation and management, remember I told you there's a section on the table and it falls within that moderate level. And as you can see here, diagnosis or treatment of significantly limited by social determinants of health. So they can utilize E&Ms as well, and for screening and documentation must support. There's also a list of other visits like inpatient hospital, observation care. These they can always bill on using medical decision making or time, whichever one they decide they can screen for social determinants of health as well. These are the new 9.8 series codes that the AMA added that I said CMS is not utilizing. Some other payers follow what CMS does, some don't. So it depends. If they don't, you have to follow and use the outpatient E&M. If they are allowing you to bill, then it's the same thing. It's new versus established patient, total time or medical decision making, and must be documented in the record. The codes can be found in the CPT books. There's appendices P, R, and T. The P is asynchronous, so that means audio and video. and they tell you which modifier to use. Also, the Appendix R, which is for the digital medicine taxonomy, same whether they're using synchronous or audio only, and it lets them know which CPT code and modifiers to utilize. And then Appendix T is that audio only services, and it lists, right, from different services, psychotherapy, evaluation and management, they're all listed there. You can also find the list on the CMS website. You can download the file, and I have linked that for you. And that would be the most recent telehealth list, right? So one thing I would note is these codes that I was showing you here, the E&M codes. So the AMA thought that CMS was going to adopt it, so they removed this. They removed these codes from the appendices. So it's still in CPT book, but they removed it from these appendices. They're no longer there, but CMS has it on their list. So that's the confusion that happened there. CMS also created screening tools for social determinants of health. So we're almost done. Hang in there. We have some questions such as within the past 12 months, the food you bought just didn't last. You didn't have money to get more, and it helps them ask certain question. Transportation question, utilities. In the past 12 months, has lack of reliable transportation kept you from medical appointments, meetings, work from getting things done for daily living, right? And these are important. Even if the medical assistants screen them, the providers, the physicians, the MDs, the DOs, the NPs, the PAs, they are the ones that have to get the diagnosis codes, right? But someone else could at least document it in the record. Screening is important. The doctor's office, the primary care specialist, they're usually the first one to identify social determinants of health. Why? Because the patients are coming in to address their chronic conditions. And oftentimes when you have that comfortable, and then patients are able to be transparent and say, hey doctor, you know what, I haven't ate in 2 weeks, I lost my job, I haven't been able to afford medications, do you have samples? These medications are too expensive for me, I can't afford it right now. I have a family member who takes a medication monthly, and monthly that medication, that one shot is $500, right? The doctors, they used to get samples, they no longer get samples, right? So they're working to try to see how they can help them get this medication monthly. In addition, this is some other tools, right? It just looks a different way. Do problems getting childcare make it difficult for you to work or study? Yes or no? In the last 12 months, have you ever had go without healthcare because you didn't have a way to get there? Yes or no? So think about it. When you screen and ask these questions, right away, your doctor or physician's office is knowing that, hey, we have some social determinants of health that we have to address, so they can get that care team together, that social worker, the nutritionist, or other specialists involved so we can address these needs. This is why documentation is important. The documentation, the medical record is a legal document. So if they go to court, if something happens to the patient and they pass away, that legal record, or if anyone needs it, everything is documented in there. The doctor documented the social determinants of health and how they try to help and address them. There are Z codes, there's diagnosis codes. So the insurance companies get a few things. They get CPT codes, HCPCS codes, and diagnosis codes that tell a story. The CPT codes are the codes that I showed you before, the office visit, the caregiver training, educational training. Then we have diagnosis codes that specifically tell these conditions. They're what we call Z codes. Some people are like, oh, we were told not to code them. No, they are important because this is telling the patient's story and letting the provider know how much they're going to cost in healthcare dollars, right? So problems related to education and literacy, problems related to employment, problems related to physical environment, problems related to housing and economic circumstances, problems related to social environment, problems related to upbringing, and there's others. This social determinants of health has impacted healthcare so much so that they added these to what we call the MCCs and CCs of inpatient. So the diagnosis, because they realize a lot of resources go into taking care of our patients. So for anyone that's going to be working in the inpatient setting, they realize, hey, if the patients have some social determinants of health going on, guess what? We got to get social workers involved. We got to get care teams involved to get them stable before we discharge them. Because guess what? If you don't, it's going to be a revolving door and these patients are going to be admitted again, right? So they impact inpatient and outpatient settings. Proper documentation helps identify risk factors impacting patients' health. Detailed SDOH ensures all team members are informed about the challenges that are affecting the patients. By documenting SDOH, providers can address non-medical barriers to health. Proper SDOH documentation is increasing required for quality reporting. There are certain measures. We have what we call HEDIS measures and MIPS measures that's usually on the back end side of the documentation, and they trigger alerts, right? They trigger when a patient is screened for a chronic condition, smoking, diabetes, they're on certain medications, and then certain measures, benchmarking. Did they have their screenings on time? And so this helps keep the patients healthy. So future potential, there are lots of remote patient monitoring devices that are out there, a lot of companies that's out there because they realize that, hey, we can monitor our patients closely. They improve visibility. So gain complete visibility of the patient's status. Staffs are automatically notified when a patient trends fall outside of the clinical threshold. AI. AI is now in the mix. A lot of hospitals, doctors' office are adding in AI into their EHR systems to help with documentation and help with screening and remote diagnostic, right? So AI-powered tools assist diagnosing conditions remotely, improving accuracy and speed. Patient monitoring, so continuously monitoring patients with chronic through AI algorithms and virtual care or virtual assistants. So this all helps bridging the gap between patients and healthcare, collaborating with community organization and leveraging data and analytics will help us improve. Best practice in implementing telehealth, you want to look at the SWOT analysis for social determinants of health, right? What is the strengths, the weakness, the opportunities and threats, right? Increase access to care, cost efficiency, continuity of care, flexibility and convenience. Weakness, digital divide, right? Limited internet access, reimbursement challenges. Not all insurance companies want to pay for telehealth anymore. They want the patients to come back to the office or they want the patients to see their providers on their platforms. So checking patients' eligibility is important. You never want to assume it's covered. Data privacy, right? Telehealth, internet risk of the internet, and we have theft of information. So we have to make sure we're using HIPAA compliant platforms when we're providing these services. As of August 9th, 2023, the OCR, so the Office of Civil Rights and HHS, Health and Human Services, require all providers to be on a mandatory HIPAA compliant platform. So they can no longer just use like FaceTime and all that stuff that they was using during the public health emergency. So opportunities, we have caregiver support, caregiver training, we have population health management, and then what are the threats? Remember I said the regulatory uncertainty, like we're not sure if CMS is going to make some of these things permanent, but I'm telling you it's not going away. Because remember, I just gave you the timeline that has been around since the 1960s. So we now just are in an era where we have to learn how to do it compliantly. Increase in disparities. So we have an increase and decrease. So health increase in the United States imposed substantial economic burden. So in 2018, racial and ethnic health disparities were estimated cost of 451 billion, making 41% increase from 322 billion. Telehealth has demonstrated potential in decreasing healthcare costs and addressing health disparities. For instance, we talked about during the public health emergency, we saw a decrease when it comes to disparities and expense of 61%. So that's a lot. So in summary, ooh, that's a lot, right? By utilizing the appropriate CPT codes, Healthcare providers can effectively address SDOH and support caregivers through telehealth platforms. Video visits allow for regular consultations and education, enabling patients to better manage chronic conditions at home. Learn how telehealth bridges the gap between undeserved communities and real health communities. Review your state laws and your payer policies in telehealth because they are changing. We have some changes. Something has only been extended until September 30th of 2025. So we're waiting to see if Congress is going to extend anything further and what's 2026 looking like for telehealth. So continue to stay abreast of the changes. Explore how telehealth improves outcomes. Documentation is needed to assess the patient's conditions properly, and many insurance plans cover telehealth, right? However, coverage will vary depending on plan to plan, as I mentioned. And don't worry, I have linked all the sources for you. So you'll get a copy you can check out the resources. You can follow me. If you have any questions, you can always email me. I'm on all the social media platforms. I write various coding articles on these topics, so you can head on over and read on social determinants of health and what's happening now with telehealth. And then these are just the various coding courses I teach, the CRC, CPMA, bootcamp, and I even created a telehealth e-guide that comes along with a checklist for organizations to help. It's on the website for purchase and Etsy. And then you can just subscribe to the newsletter to stay abreast of anything telehealth and social determinants of health. And that is all. I want to thank you guys for being amazing and sitting for this. I know it was a lot. I told you we could talk about this for like years because there's so much information.
This is beautiful. Does anyone have any questions for her before we let her go? All right, Jody says
No
no
questions.
questions.
Oh.
Okay, well, again, we want to thank you so much for joining us. Thank you for sharing this information with us, Keisha. This is beautiful. You're so passionate about what you do, and it comes across every time I see you present. So, thank you so much for sharing your knowledge with us, and we will definitely be in contact with you to see
Huh?
how we can learn some more from you.
Yes, yes. Thank you so much. I hope everyone has an amazing rest of the day, and I look forward to seeing you guys virtually or in person sometime.
All right, take care, everyone.
Have a good day.
Bye bye.
Bye bye.